Welcome to today's webinar. We're letting everyone enter the room. It's going to be a minute or so before we get started, so just bear with us for a moment. We have a great faculty lined up today. I think we're going to have a lively discussion. A lot of confusion out there about aspirin, when it's appropriate. What's the difference between primary prevention and secondary prevention? Big differences in the guidance there, which has changed. A lot of questions, a lot of patients confused. I have to say, a lot of people calling all of our offices saying, am I supposed to stop my aspirin? I'm getting a lot of calls from relatives. So a lot of confusion, and we want to clear a lot of that up today. We have about 430 people registered for today's webinar. We'll give them a little time to join. The webinar is going to be archived. You can access it online after this recording's done. We'll have a pre-test, we'll have a post-test. After the pre-test, we'll go ahead and have the didactic portion of the webinar. And then at the end, you can do the post-test to see if we've met our learning objectives. We're gonna get started here just a minute or so after the hour, so just bear with us another minute or so while people continue to join the webinar. Thanks. Great. Well, thanks for bringing the first slide up. Thanks for joining our webinar today. We're talking about aspirin in 2022, where we are, where we're going. I'm Mike Gibson. I'm a professor of medicine at Harvard Medical School and the host of today's webinar. We have a great faculty lined up for you today. Next slide, please. This activity is planned by and for a healthcare team, and that includes doctors, includes nurses, includes pharmacists. So all those different practitioners are getting credit for the program. Now we're going to be recording all three roundtables today: a physician roundtable, an advanced nurse practitioner roundtable, and a pharmacist roundtable. You can listen to all three of them. They'll all have different perspectives. When this is archived, you'll be able to access the roundtable discussion for your specific practice. The content was developed by the faculty that you see here. It's intended for cardiologists, internists, family practitioners, primary care physicians, pharmacists, nurse practitioners, PAs, and nurses. It's meant to be fair and balanced and free of commercial bias. Next. This is my grant support. I run a couple of research institutes at Harvard, so I have a lot of relationships to disclose. I have research grant support from every major manufacturer of antiplatelets and antithrombins. Next. This is the disclosures of Eva Klein Rogers, just a few here. Next. These are the disclosures of Dr. John Finicos, pharmacist. Next. And these are the disclosures of Dr. Dominic Angelillo. Like me, he also has some research grant support from all the major manufacturers of antiplatelets. Next. So what are our learning objectives? At the end of today's program, you'll be up to date on the latest guideline statements about aspirin in the setting of chronic CAD, STEMI and non-STEMI. You'll know the difference between primary and secondary prevention. You'll know how to tailor the dose and the formulation of aspirin for a given patient. You'll understand all the different formulations that are out there now, and you'll be able to explain it to patients, and you'll be able to use it in practice to tailor the use to the patient's individual risks and benefits. Next. Let's look at the history of aspirin. Aspirin goes 4,000 years back. I mean, the Sumerians were using it mostly for pain relief. Back in 1899, Bayer introduced what we know today as aspirin. In the middle of the last century, we began to realize that aspirin has benefits in the setting of acute coronary syndromes and in the setting of PCI. That was the good news. The bad news was we began to realize there was some GI upset and bleeding with aspirin use. That led to newer formulations like enteric-coated aspirin. And we're going to talk about some of what we've learned about enteric-coated aspirin over the past few decades. We've had the introduction of some new antiplatelet agents, the thienopyridines, the P2Y12 inhibitors as they're known. What we've learned when we use the thienopyridines is that less may be more when it comes to aspirin. And there has been a use of low-dose aspirin, 81 milligrams, as part of the DAPT regimen in recent years. There's also been a tendency to stop aspirin a little earlier, particularly in the patient with atrial fibrillation, and we'll get into that a bit as well. Next. Where are we today? Well, aspirin does remain the foundation therapy for secondary prevention. Really very clear in the guidelines. We'll talk about in the next slide the recent recommendations from the United States Preventive Services Task Force and how that changed things. But I want to begin with, before we get started with some of the review of the guidelines, let's start with a pre-test question here. So does aspirin carry a class 1 recommendation for secondary prevention? Please click on the buttons to give your answers here. Yes, no, or don't know. The second question we want to ask you before we get into all the didactic information is the speed and extent of absorption poor with enteric-coated aspirin compared with regular aspirin and phospholipid-coated aspirin. So is enteric-coated aspirin absorbed slower? Yes or no, or don't know. And then does phospholipid-coated aspirin reduce gastroduodenal ulcers and erosions compared with regular aspirin? I'm going to answer that one, yes or no. So we asked you these 3 questions to establish what you know before the didactic content. I gave you a little hint on those first ones. So do your answers, hit the submit button, and that way we can move on. Let me give you another few seconds to hit the submit button. Great, well, hopefully all of you have submitted your answers. Getting back to some of the didactic information, aspirin today, again, foundational therapy for secondary prevention. There's been a tendency to shorten dual antiplatelet therapy. We're going to get into some of the our understanding of that and some of the limitations of the data that are out there. But there's a lack of awareness of some of the newer formulations of aspirin that may have some advantages. And Dr. Angelillo will talk about some of the potential advantages of a new phospholipid-coated aspirin. When we get done with the didactic sessions, we'll then have some roundtable discussions to focus on some of the big questions that are still out there. Next. So what's primary prevention? Primary prevention is where we are trying to prevent that first event, that first heart attack or that first stroke. Secondary prevention is when we are trying to prevent a recurrence of that event. We know they have the disease, and we're trying to prevent that second heart attack or stroke. Next. Very important to understand that, because to understand the guidelines, you have to understand where the restriction is. The new guidelines state that for primary prevention, this is preventing that first heart attack or stroke. What they say is that if you are that 40 to 59-year-old age bracket, and if you face a 10% or higher 10-year risk, then you could consider, aspirin use. Now that's assuming that you don't have a risk of bleeding. If you are over 60, for primary prevention, the guidelines say, be careful there. That's not widely recommended. Again, all of these are individual decisions. You should make these decisions in conjunction with a healthcare provider. And before stopping the medicines, what we're telling our patients is check in with your healthcare provider to make sure that's the right decision for you. Next. So one of the messages we've been getting out there is don't discontinue your aspirin without talking to your healthcare provider professional. Next. Well, here's a typical case. This is just someone we would see every day in our cath lab, a 52-year-old woman with a history of type 2 diabetes. We're going to talk a lot about how diabetes changes risk and how diabetes makes it very important to get the aspirin dosing right. This person had no prior history of heart disease, but presented with ST elevation. We are seeing more and more young women present with STEMI. You know, this is not a disease of men. It strikes men and women equally. It's still the leading killer of both men and women in the United States. So important our patients recognize that. They had ST elevation in leads V2 to V4, got some oxygen. They got a full dose of chewable aspirin in the ambulance. And we'll talk about why it's important to give non-enteric coated aspirin in those very early settings. The patient was pretty hemodynamically stable, a little tachycardic, but note the BMI. The BMI was 34, and obesity and, you know, the large size of many of our patients, you know, that does affect some of the aspirin dosing, and we'll get into that. The LAD was opened, a DES was placed, things were uneventful, and then the big next question is, what do you do next? Next slide. So is this a primary or secondary prevention patient? This is, let's do your answers here. What would you say? Is this primary or secondary prevention? Click your answers, and then we'll submit. And then which antiplatelet regimen would you put this person on? Would you put them on immediate release aspirin, regular aspirin with clopidogrel for a year? Would you give them enteric-coated aspirin, 81 milligrams with clopidogrel? Would you give them enteric-coated aspirin or one of the more potent drugs like prasugrel or ticagrelor? Would you give them the newer drug that we're going to talk about, Vazalore, that's an 81 milligram dose coated with phospholipids with clopidogrel? Or would you give them that newer drug, Vazalore, the 81 milligrams of phospholipid coated aspirin with, say, prasugrel or ticagrelor? Vote and then submit your answers. At 1 year, then the next question is, what do you do at a year? Do you discontinue everything, or do you continue aspirin at 81, enteric-coated, the phospholipid-coated aspirin, or clopidogrel, or ticagrelor, or prasugrel, or discontinue DAPT? So looking forward to seeing your responses. Hit the submit button so that we can move on. I also think these are important questions for discussions in our round table. So I'm going to kick things over to Ava Klein-Rogers. She's going to talk about the history of aspirin that led to our practice changes. How do we measure aspirin and adherence? And she's going to talk to us a little bit about the guidelines. So Ava, take it away.
Great. Thank you so much. So let's go to the next slide. I do want to spend a little bit of time going over the data that brought us to where we are today. So even though I hate to admit this, I remember when this study came out because I was a clinical research coordinator working on thrombolytic and primary PCI trials. And this had a huge impression on our group. It's like, oh, we got to make sure we're giving aspirin. So this was the ISIS-2 collaborative group, and this was published in 1988 in Lancet. And the results were that the effects of aspirin and streptokinase were independent. Aspirin reduced mortality whether patients received streptokinase or placebo. And this sort of blew us away when this first came out. And this led to a direct change in practice. So EMS services as well as ED nurses were now told to give immediate release aspirin for suspected AMIs. Next slide. So what about secondary prevention? So we know that became practice change for primary prevention. Well, this is a great study that came out, and this is from the Antithrombotic Trialist collaboration, and this was published in 2002. And they looked at 195 randomized trials with over 135,000 patients, with the primary endpoint being serious vascular events like MI, stroke, vascular death. So all patients who were treated with antiplatelets, the majority of which were treated with aspirin, had a 10.7% severe vascular event rate versus 13.2% for those who were treated with control. So this led to the recommendation of aspirin being given to all patients for secondary prevention. Next. Of course, there's always caveats. So this is from the same publication, and the authors noted that, okay, aspirin reduces mortality, but there is a trade-off. There is an increase in the number of major bleeds. So you can see in the fourth column across the stratified odds ratios for having a major bleed in those patients who were given aspirin. And this, along with other trials, led to us reducing the dose of aspirin in these patients. Next slide. So how good are we as providers and as patients in actually following these recommendations? Well, unfortunately, it's always disappointing, but we're not all that good. So this is the REACH registry that was a global registry looking at outpatients. There were over 25,000 patients enrolled here in the US. This was published by Dr. Cannon. And the results showed that nearly a quarter of patients with vascular disease were not treated with aspirin for secondary prevention. And in fact, 15% were not treated with any antithrombotic agent. In a similar registry in Sweden, and this is in over 600,000 Swedish users of both low-dose aspirin for primary and secondary prevention, noted that there was a very high discontinuation rate. And this was despite ruling out and not counting those patients who had major surgery or bleeding. That discontinuing the aspirin was associated with a 30% increased risk of a cardiovascular events. And we know as practitioners that this is a little bit challenging because I know in clinic, I see patients often that don't consider aspirin a prescribed medication, and it's available over the counter, and there's tolerability issues. So there's a lot of challenges with this little aspirin pill that we think is so easy to prescribe and for patients to take. Next slide. So what are the practice guidelines? Well, most of them have not changed, except recently in 2021, their revascular guidelines were updated to reflect recent studies to shorten DAPT for stable ischemic heart disease. Next. So the first half of this slide deals with non-ST elevation MI, acute coronary syndrome, and PCI. And you can see that non-enteric-coated aspirin for all patients promptly after presentation is a 1A recommendation, along with aspirin maintenance dose continued indefinitely. That is a 1A recommendation. And you'll see that the dosages vary, and we'll talk more about that. For STEMI patients with PCI, a non-enteric-coated aspirin for all patients is a 1B recommendation. Aspirin continued indefinitely is a 1A. And then low-dose aspirin as preferred maintenance dose is a 2B B recommendation. Next. I like this algorithm, which was just published recently after the revascularization guidelines were updated. So on the left side of the slide, you see stable ischemic heart disease. On the right side are acute coronary syndrome patients. So if we look at the left side, the stable ischemic heart disease, it's divided by drug-eluting stent and bare metal stent. So for drug-eluting stent patients, they should have at least 6 months of aspirin plus clopidogrel. That's a class 1 recommendation. You may continue aspirin after 1 to 3 months with continued P2Y12 monotherapy. That's class 2A. With patients, if they have a high risk of bleeding or overt bleeding on DAPT, then discontinuing the P2Y12 after 3 months may be reasonable. And for all of these categories, if patient has no high-risk factors for bleeding or no overt bleeding, continuing this therapy beyond the recommended period is reasonable. That's class 2B. So what about patients with bare metal stents? At least 1 month of aspirin plus clopidogrel is a class 1. Again, if no high risk, you can continue it longer than that if you wish. For acute coronary syndromes, and this is where the difference is between the stable ischemic heart disease and ACS, the recommendations are at least 12 months of aspirin plus P2Y12 inhibitor. So the caveats here are you may discontinue the aspirin after 1 to 3 months with continued P2Y12 monotherapy. That's a class 2A. If patient's at high risk for bleeding or has overt bleeding, continuing it, the P2Y12 after 6 months may be reasonable, class 2B. And again, you can continue it on if needed, if there are no high risk features. Next slide. So is there a difference between aspirin and the P2Y12 inhibitors? Well, the fast, easy answer to that is no, there is no difference. So here's the data that support that. So this was published in 2020 in Lancet, and this was also a meta-analysis of over 42,000 patients from 9 randomized trials. So a comparison was made between those patients who were on long-term aspirin for secondary prevention versus a P2Y12. There was a borderline reduction for the risk of MI with odds ratio of 0.81. The number needed to treat was 266, which many consider to be pretty high. There was no difference in risk of death, stroke, or major bleeding with odds ratio of 0.90. So one of the key points here is that this is a discussion that needs to happen between provider and patient to determine what specific risks patients have and which drug may be most appropriate and length of therapy most appropriate. So next slide. What we do know is that if DAPT is continued in an unplanned fashion, patients don't do well. So this was published recently in the Journal of American College of Cardiology Interventions, and also a multi-center registry, over 8,000 patients who were on clopidogrel and aspirin after PCI with stenting. And the number I want to highlight is that there 18.3% of these patients continued, were discontinued their therapy in an unplanned way. And the reasons for this unplanned discontinuation included surgery, trauma, non-adherence, bleeding, or drug allergy. But the problem is the risk of cardiovascular events increased significantly with a particularly high risk less than 1 week after discontinuation. So for me, the take-home message is always emphasize with our patients, do not stop these drugs without having a conversation with your doctor or provider first. Next slide. So these are the current guidelines for ASCVD patients for secondary prevention. So in stable ischemic heart disease, aspirin is a 1A recommendation. Clopidogrel, if patients are allergic or intolerant to aspirin, is 1B. For patients with peripheral arterial disease, either aspirin or clopidogrel is a 1A recommendation. And for patients who've had stroke or TIA, aspirin is 1A, clopidogrel is a 1B recommendation, and aspirin plus dipyridamole is a 1B recommendation. Next. And lastly, I wanted to round it out with this. Dr. Gibson mentioned diabetes and it being a separate risk, and it needs to come into play when we do all risk assessments. So this is a summary of what the American Diabetes Association, a combination of ACC, AHA, and the American Diabetes Association, and then the Europeans' recommendations for primary prevention in patients with diabetes. So the ADA says, consider aspirin for primary prevention for type 2 diabetes with a 10-year CVD risk of greater than 10%. Not recommended for adults with type 2 with low CVD risk or younger than age 50. And low dose aspirin recommended for pregnant women with pre-existing type 1 or type 2 to lower risk of preeclampsia. The combined statement of AHA, ACC, and ADA reads that it's reasonable among those with a 10-year CVD risk greater than 10% without an increased risk of bleeding, and it's reasonable in adults with diabetes and intermediate 10-year CVD risk of 5 to 10%. And finally, the Europeans are a little bit more conservative, so they say antiplatelet therapy is not recommended for people with diabetes who do not have ASCVD. So again, this is in primary prevention. And I'll hand it off to the next speaker.
Thanks so much, Ava. We're going to turn now to John Panicos. John?
Thank you, Mike. John Panicos, pharmacist at Brigham and Women's Hospital. So here is my outline. I'll talk about aspirin prescribing, its mechanism of action. We'll focus on formulations briefly, and then finish with costs and considerations. So next slide, please. So again, let's start with professional prescribing. Next slide. I don't think many people recognize this, but there is actually FDA approved labeling for aspirin. You can see the over-the-counter recommendations for its use as a pain management strategy. But for the purposes of our discussion, I think the most important part of this labeling is messaging that goes directly to the prescribers, specifically physicians and support providers like nurse practitioners, physicians assistants, and pharmacists. But if you look at this closely, it surrounds the recommendations that aspirin is indeed indicated to prevent future ischemic events like stroke, myocardial infarction, and the occurrence of recurrent MI in the setting of past MI, unstable angina, and chronic stable angina. It's also indicated to prevent recurrent events in the setting of revascularization procedures like CABG, like PCTA, and endarterectomy. So labeling for aspirin, somewhat unusual for an over-the-counter product. Next slide, please. The mechanism of action of aspirin was elucidated in the 1970s by a physician, John Vane, in the United Kingdom. And if you look at contemporary reviews, not much has changed. We know that aspirin exerts its activity by inhibiting the cyclooxygenase family of enzymes, cyclooxygenase 1 or COX-1. By inhibiting that enzyme, you prevent the conversion of arachidonic acid to prostaglandin to ultimately thromboxane A2. Thromboxane A2 is a lipid that excites, aggravates, agitates platelets, and causes aggregation. It's also a potent vasoconstrictor, and it causes muscle cell proliferation. So it is a culprit that you want to suppress in the setting of existing ischemic disease. Aspirin also inhibits COX-2. In larger doses, it has this anti-inflammatory effect to not only inhibit platelet aggregation, but also produce this anti-inflammatory activity. All of this, again, becomes an important aspect in its activity at low doses for prevention of events. It also has activity in terms of its use in pain and chronic ailments at higher doses. So next slide, please. Let's focus on the different formulations for a few minutes. People recognize that there is an immediate release of what is referred to as plain aspirin. It is typically considered the gold standard for its pharmacokinetic, pharmacodynamic effects for inhibiting thromboxane production. Most individuals recognize that there is a chewable formulation, and we use that in the acute setting primarily because chewed aspirin exerts its antithromboxane effect within 5 minutes. You can see a 50% reduction in thromboxane levels within a short period of time. So it's often used in that setting and chewed. Now, I challenge you to find plain aspirin in a retail pharmacy. You'll find lots of different formulations, lots of different delivery systems, but plain aspirin at 81 milligrams is typically not available. And so we advise patients to focus on using the chewable baby aspirin formulation that's routinely available. Over the past 50 years, there have been numerous attempts to make the tolerability of aspirin easier for individual patients. And that has led to a series of delayed release or enteric formulations that have tried to improve its tolerability as far as GI side effects. Next slide, please. So if we look at enteric-coated aspirin in different formulations, the quality of evidence is not clear in terms of its effectiveness. You can look at my references down below. And again, we've been studying enteric-coated aspirin for over 50 years. When you look at these formulations, the absorption tends to be erratic. And because of that erratic absorption, you have a tendency towards a variable antiplatelet effect. So the aspirin response may not be complete in many patients that have underlying cardiovascular disease. Coating the aspirin or buffering the aspirin with agents like magnesium carbonate or calcium carbonate or magnesium oxide, both of these strategies have not shown that they consistently reduce the GI side effects and specifically GI bleeding. Now, let's go through the individual details of each one of these quickly. Next slide, please. So where is the evidence for enteric coating as a gastroprotective effect? Well, the intent of the coating, and there's a number of different sugars and polymers that can be used to coat aspirin, is to allow it to pass through the gastric contents and now be absorbed in the small intestine, specifically in a less acidic environment of the duodenum. But when you look at the studies that have done a systematic review comparing aspirin formulations, specifically plain aspirin, buffered aspirin, and enteric-coated aspirin, the GI complications occur about twofold higher with plain aspirin, about 5 times higher with buffered aspirin, and about 2.5 times higher with enteric-coated aspirin compared to controls. So truly, these strategies don't really do much in terms of reducing GI complications. And another review, including 15,000 participants that included 9,000, almost 10,000 patients with enteric-coated aspirin, there was no difference between the 81 milligram strengths and the placebo patients in terms of protecting the GI tract from complications in patients. So the next slide, please. The benefits of enteric-coated aspirin in terms of tolerability has not been proven. It also leads to issues with absorption. So this is the study that looked at the absorption of enteric-coated aspirin compared to plain aspirin in a population of healthy patients. These are patients with no underlying cardiovascular disease. They were treated with both plain aspirin and enteric-coated aspirin. In the graphic to the right, you can see that the bioavailability as measured by plasma salicylate levels is pretty consistent over time with plain aspirin in the fasting state. It's a little bit delayed in patients in a fed state. When you look at enteric-coated aspirin at the bottom, you can see that the absorption is greatly delayed, even in the setting of fasting patients, but significantly delayed in patients that are in the fed state. And in many instances, you don't see any salicylate activity until 4 hours after administration. Importantly, in almost a third of the patients studied, there was no detectable salicylate levels after 10 hours. So there's
That's really interesting. I mean, here we recommend people take their aspirin with food, but that's really kind of really concerning that about a third of people had no active drug in their body after food.
no active drug, Dr. Gibson. And I think, we, because of its ubiquitous nature of aspirin, its availability, take for granted that these formulations are working. And I don't think we've looked close enough really and accepted aspirin as a routine therapy without a lot of evidence. Next slide, please. Similarly, the same group looked at the effects on antiplatelet activity. This was in a group of healthy volunteers, again, a crossover study. This time, rather than looking at salicylate levels, they looked at levels of thromboxane B2, which is an inactive metabolite of thromboxane A2, so a surrogate marker, if you will. But you can see in the graphic to the right the different formulations, the whisker lines showing the 95 and 5% confident intervals, the black dots showing the outliers. And I think the important message is if you look at plain aspirin, the performance surrounding antiplatelet activity is pretty tight. When you look at the other formulations, including astaxanthin, which was a combination of aspirin and dipyridamole, you'll see a wide variability in antiplatelet activity. So it's pretty clear that in equivalent doses, the enteric-coated aspirin was not as effective as plain aspirin in this group of healthy volunteers. Next slide, please. Yeah, there we go. Thank you. And then if we look at a group of patients with underlying cardiovascular disease, so these were 131 patients who were taking aspirin 75 milligrams on a routine basis. Again, in this study, they were looking at thromboxane B2 levels as an indicator of antiplatelet activity. And when they administered these doses to this group of patients, there were two obvious groups that appear. In the bottom graphic, in the graphic at the bottom left, you'll see there's patients who have a reduction in thromboxane B2 and a reduction in platelet aggregation. But yet there's another group that the administration of enteric-coated aspirin seems to have no effect in producing antiplatelet activity. This was more disturbing in that the younger patients and those that were heavier, when they looked at patients in 10 kilogram increments of body weight, were more likely to have an inadequate response in terms of antiplatelet activity. So I think the message here is we need to have some concerns about the different aspirin formulations. Next slide, please. And again, the suggestion that there is a benefit of aspirin formulations, either enteric-coated or buffered doses, in reducing upper gastrointestinal bleeding. This was a study that emanated here out of Boston. They looked at 550 cases of patients that developed upper GI bleeding. This was endoscopically confirmed. But if you look at the graphic to the right, the agents like enteric-coated aspirin and buffered aspirin showed no benefit in reducing GI bleeding when compared to just plain aspirin. So the takeaway messages are, again, that perhaps there is no benefit in terms of these suspected values or advantages. Next slide, please. There are solutions for GI intolerability with aspirin. To the left is the recommendations for antiplatelet therapy that emanated out of the ACC-AHA and the American College of Gastroenterology, that you should assess patients in terms of their GI risk. If there is an opportunity to remove H. pylori as a source of peptic ulcer disease, you should do that. And then perhaps combination with using a proton pump inhibitor, especially in those agents that are elderly and those patients that have other GI therapies like that could disrupt the GI tract, like corticosteroids, or those with a history of dyspepsia. Why PPIs? It has been compared to H2 antagonists like cimetidine, ranitidine, famotidine, and the proton pump inhibitors perform better than these agents. There are other strategies like using misoprostol that have fallen out of favor. And even though the doses of that agent are low, they tend to have their own toxicities in generating diarrhea. So the strategy that is recommended when necessary is to invoke the use of a proton pump inhibitor. Next slide, please. So let me, the cost. I don't know a single medication that you can't consider inexpensive. Even in the face of aspirin, there'll be patients who tell you they can't afford it. There are clearly lots of patients taking aspirin. The dose of 81 milligrams is as good as 325. There are lots of strategies to find aspirin in inexpensive combinations, but I'll also tell you that we use aspirin with other agents that are expensive, and in the portfolio or the medication profile of patients, there has to be some juggling of the cost of different medications and the value. And I think that's the important message that we need to be giving to our patients, is to be able to afford and take the medications that are prescribed. And I'll finish there. Thank you.
Great, thanks, Sean. And we're now going to turn to Dominic Angelillo. Dominic?
Yes, thank you, Mike. So this has been great so far, and I'll try to summarize a few things as it relates to some of the pitfalls of current aspirin formulations, and provide insights on new aspirin formulations, and then lead this into the discussion. So over the next 10 to 15 minutes, I'll speak about potential opportunities for improving the effects of aspirin. We'll speak about balancing the benefit and risks of aspirin therapy. What does it mean to have aspirin-induced GI toxicity, and how this compares with P2I12 injury? We'll speak about some of the new approved investigational agents, including Vazalore. We'll speak about impaired aspirin response and weight considerations. And finally, we'll wrap up with some take-home messages. Next slide. So definitely there are opportunities for improving the profile of aspirin, both on the efficacy and the safety side. And you can see here from the efficacy, we have, as Mike taught me many years ago, the rule of 3 Ps: prompt, potent, and predictable. So prompt, because we want a drug that kicks in quickly, and to do this, it has to be rapidly absorbed, and we assess that by looking at the PK. Potent, based on the degree of inhibition, and we look at that by looking at the PD. And predictable, because we want a consistent response, right? And we want to limit as much as possible individuals who are poor responders, and we know that there are cohorts that may be at higher risk for this. And from the safety perspective, we can add a 4th P. We want something that is protective against GI injury, which, as we all know, is the major drawback associated with aspirin therapy. We know that aspirin works, aspirin is very effective, but this is the major pitfall. Next slide. So we have already heard from the prior presentations, we have a very clear class 1A recommendation for the use of aspirin secondary prevention. That means that, aspirin is clearly an efficacious drug. But our main concern, as mentioned previously, is the safety profile of aspirin related to GI toxicity. Now, when we speak about GI toxicity is not just bleeding. It's also everything else that may come along with irritation of the GI mucosa, which includes, for example, stomach discomfort, dyspepsia. Okay, so it's a broad range of symptoms. And because of this, patients don't like to feel miserable, right? So what do? They can stop aspirin. And in secondary prevention, that's not a safe thing to do because it exposes patients at increased risk of a thrombotic complication. So even though the prevalence, for example, of a GI toxicity that leads to a GI bleed may not be that high, if we think about the millions and millions of patients that are out there taking aspirin, even a small number, okay, a small percentage leads to overall over a large number of patients that are at risk. Now, what are the pathways that lead to a GI injury? There are two main pathways. There's one which is local and the other one which is systemic. Next slide. I'll explain these into a little bit more detail. Let's start off with the systemic pathways. The systemic pathways are related to one, and we know that aspirin is an antiplatelet agent, and by definition, there's an impaired hemostatic function. Okay, and two, there is inhibition of our protective prostaglandins. And we know that this is key for protection of the GI mucosa, also for microvascular perfusion, as well as wound healing. So if you impair these, okay, on top of the local issue, which is related to binding of aspirin with the protective phospholipids in the gastric mucosa, well, that is what leads to GI toxicity. Now, what we don't know, what is the relative contribution of each one on the overall GI toxicity? That remains unknown. But what we do know that there are opportunities to improve, at least, for example, on the local pathway, because once aspirin is absorbed, it's inevitable that what is systemically circulating is going to have its effects. Next slide. And here is, again, an example of what happens locally. And as mentioned before, the gastric mucosa has the protected phospholipid layer, and because of the direct interaction between aspirin or nonsteroidals in general with the hydrophobic phospholipid layer, this can lead to a disruption. And by definition, when you eliminate that protection, okay, then you have exposure to the acidic environment, for example, in the stomach, which perpetuates the whole process of GI toxicity. And if you add to that the systemic component, again, the impaired hemostasis and the inability to protect because of the impact on prostaglandins, this is what leads to the overall damage associated with the use of aspirin. Next slide. So there have been a lot of debates whether this is a property just related to aspirin or also other agents such as the P2Y12 inhibitors. I found this to be a relatively recent study, which I found to be rather interesting, published by Dr. Han and colleagues in China, published in JACC. What was pretty interesting about this analysis, which was a double-blind, placebo-controlled study using a capsule endoscopy study. And there were patients who were on aspirin alone, patients on clopidogrel, and patients on DAPT. What we do know is that if patients on DAP were those who were obviously at highest risk for developing a GI injury, but it was rather interesting to see that patients also on a P2Y12 inhibitor, this was essentially mostly clopidogrel, had similar effects than aspirin. Again, this is one study, but it also speaks to the fact that there are probably multiple factors, and definitely the systemic component has an impact on the GI toxicity associated with antiplatelet agents. Next slide. So here you see a slide which summarizes the currently the new available formulations and those that are investigational. We've alluded to already a few times during this presentation to Vazalore, which is a liquid-filled capsule, which contains a phospholipid and aspirin complex available both in 81 and 325 milligram formulation. I'm going to speak a little bit into details in some of the studies. In Europe, there is a combo drug which contains both aspirin and clopidogrel. I actually used it when I was practicing in Europe. They changed name from Duocover to Zentiva, and there are a number of investigational agents which also include an inhaled formulation. Next. So let's speak a little about mechanisms to reduce GI toxicity, and we already spoke about the systemic pathway and the local pathway. And there's been a lot of interest for a number of years on identifying new aspirin formulations. We already spoke about that previously, but one of the mechanisms that has been assessed is by binding aspirin with a phospholipid. Now, this is something that was not only done study with aspirin, but also been tested with other non-steroidals. And you can see from this study performed in animal models that a pre-association with aspirin with phospholipids is able to maintain gastric hydrophobicity and also hematocrit levels. Next slide. So now if we take this concept, again, it's a concept which is rather old, and we look into this new formulation of aspirin, of Vazalore. Here you see exactly what is happening. As you can see from the slide, we have a capsule, which, as mentioned before, is liquid filled with a lipid complex where there's a binding with aspirin. The capsule, obviously taken orally, dissolves in the stomach where we have a low pH, and here you can see the liquid lipid aspirin complex. Now, this complex stays united at low pH. Okay. But what is interesting about the complex, and this is something that we've learned through different formulations, and this stems from animal studies, that this gives the opportunity of this complex to bind with the GI mucosa and facilitate the absorption, but at the same time also serving almost as a barrier towards this damage generated by direct interaction with aspirin. Now, the complex does dissolve at a higher pH, so that would be obviously more downstream in the duodenum, and where aspirin obviously can continue to get absorbed. So it's a very unique formulation, again, designed to reduce the local injury. Next slide. And I'm going to go quickly through some of the data that's out there. Here you see some of the first data. And again, this is all in humans, in over 200 healthy volunteers, a randomized blinded study showing how compared with plain aspirin. Vazalore, formerly known as PL 2200, reduces the incidence of erosions and or ulcers. And so again, this was with endoscopy performed at baseline and at day 7, and with all endoscopies centrally adjudicated. And so again, supports the concept of what we just saw in the prior slide. Next. This is the bioequivalence study that was reported to the FDA for drug approval. Bioequivalence, in other words, means that the PK, so absorption of the drug, need to be similar to that of plain aspirin, of immediate release aspirin. In fact, the label for Vazalore is that this is at all effects an immediate release formulation. And as you can see, that when we look at drug levels of either acetylsalicylic acid or salicylic acid, the curves are essentially superimposed. So again, it works exactly like an immediate release formulation. Next slide. We spoke a little bit about the impact of food on drug absorption, particularly with the enteric-coated formulation. Here you see the impact of food with Vazalore. You can see the two lines in green and in dark blue. Essentially, there's a very limited effect of food on the effects of Vazalore. I would say even to a lesser extent from what we've seen from the historical study previously shown with the plain aspirin. So important finding. Next slide. Here you see expanding. We went on from studies in healthy volunteers to studies conducted in patients, obese patients with diabetes, where the comparison was between Vazalore, plain aspirin, and enteric-coated aspirin at this point, using the 325 milligram. And I'd like to highlight again how how Vazalore in blue works very similarly to an immediate release in black, okay? But when we look at in gray at the enteric-coated formulation, you see how there is a delay in absorption, okay? And there's less drug. So it is not prompt and it's not potent. And we're going to see in the next slide how it's not predictable. So next slide. Okay, so here again, this is another way of looking at responsiveness, and this is the time to antiplatelet effect. The Vazalore in blue behaves very similarly to plain aspirin, but here you can clearly see how when you use an enteric-coated aspirin, there's this strong delay in achieving its effects. So next slide. And here there's the component of predictable, okay? So when we speak about predictable is how each individual responds to that given agent. And what we like to see is that there's consistency. We want to see the lines as close as possible. This is inhibition of thromboxane formation, which is considered the gold standard to assess complete inhibition of COX-1. And here you see the data of individuals achieving greater than 99% inhibition thromboxane generation. And you can see that this is almost twofold higher than that achieved with enteric-coated aspirin. So you can see in the middle panel where Vazalore, there's a lot of blue, so a lot of consistency in effects. Very similar to that of plain aspirin, although with aspirin, you have a lot more red. Okay, so individuals that are not achieving that full effect. But if you look on the other side, the enteric-coated formulation, the data are scattered all over the place. So definitely not predictable. Next slide. We recently reported the data with the 81 milligram formulation. What we've seen so far is a 325 milligram. And this again done in healthy volunteers. And we see the same exact thing. And when we look at the absorption of the drug, you see here in purple, compared this time to enteric-coated aspirin. Okay, enteric-coated aspirin is not prompt, it's not potent, and it's not predictable. On the contrary to Vazalore, where the drug kicks in quickly. You see on the bottom part of the panel where it's more potent, and obviously there's more predictability, which you do not see exactly on this cartoon. So replicable findings with the 81 milligrams. Next slide. There were some comments earlier about weight. And this is something that we've known now for a number of years when it comes to enteric-coated formulations. One of the things, however, we've analyzed with the data using Vazalore, that it is less weight dependent, and more specifically with enteric-coated formulations, it appears that where platelets start not to respond well is around that 90-95 kilo, and we shift that weight up to over 131 kilos. So these are pretty big patients using Vazalore. Next slide. So what are considerations for healthcare providers in general? Well, we wanted to educate the patient on the importance of compliance. There's a lot of data out there referring to non-responders, but the patients are not taking aspirin. So make sure patients are actually taking aspirin. We want to eliminate any interfering substances such as ibuprofen because of the drug-drug interaction. We want to make sure that patients are taking the drug without food. Okay, that's very, very important. In some patients, there may be an indication for the use of PPI. There's a lot of talks about tailoring doses according to different patient profiles. Maybe we can speak about that a little bit later. And we now have formulations that do provide more reliable absorption, which means better bioavailability. And this is Vazalore, which is an equivalent to an immediate release formulation, and also with less acute GI injury. And this is very important because it also guarantees better adherence. Next slide. Okay, so to conclude, we know that aspirin is a key component of the armamentarium of medications used for secondary prevention in our patients with established atherosclerotic disease. And we know that many times this is being used in association with a P2Y12 inhibitor, as we heard from an earlier presentation. The duration of that, however, is a lot of discussions there. We can speak about this also a little bit later, but each patient is different. But what is key, that aspirin remains an integral part of the overall long-term therapy of patients with atherosclerotic disease. We do have newer formulations right now which provide better PK and better PD, definitely compared to an enteric coated formulation. Next slide. So we'll go back to our case. Mike already presented the patient.
Yeah, we're going to have to be briefed on Mike. We're running out of time. So
okay, we can go to the next, directly to the questions. Mike, do you want to run this from here?
Yeah, so, all right. So in this 52-year-old diabetic, obese person with a STEMI, what would be your antiplatelet choice? That's at the top here. Immediate release aspirin, enteric-coated aspirin, and what would you use it with? Vote. And at 1 year, what would you use? That's the second question. And submit your answers now. So what would you use at a year, as well as what would you use acutely? Let's submit our questions and answers. Next. So we have a lot of questions. You know, is aspirin alone enough? Is P2Y12 monotherapy enough? Should it be aspirin monotherapy with clopidogrel? You know, we have a lot of evolving stent technologies. Do we need newer drugs with those? What's the best time to take it? Can you take it every other day? Should you take it with or without food? I think we've seen pretty clearly that it's probably not a good idea to be taking enteric-coated aspirin in particular with food. Really delays the absorption. A lot of people had no absorption, so that does not seem to be a good idea. So let's now quickly move to our roundtable discussions.